Hi, I am here to talk to you today about postural orthostatic tachycardia syndrome, or POTS, and long COVID, and how they might be related illnesses. Many people now divide their life into before COVID and after COVID, but for my family, we really divide our life into before POTS and after POTS. So, as you can probably notice here, I adopted two beautiful little girls from China, and we had really a normal life that you would have with little children for our first 10 years. And so we were out doing all sorts of things and having a grand old time. And then my oldest daughter, Lily, turned 10, and within a month, she developed an illness and unfortunately never got better. So we have just crossed the 10-year anniversary of her illness, and she has literally been sick for half of her life now. And that has changed her life dramatically, of course, but it's also really changed our lives as well. And so the POTS really impacts the entire family. And frankly, I wouldn't be here giving this talk today if this hadn't happened to my beautiful daughter, Lily. So I want to talk a little bit about what POTS is and why we should care about it, and then we'll bring long COVID in. So both of these illnesses really are chronic invisible illnesses, and like my daughter, instead of getting better in a couple weeks or a month, the illness goes on for years to decades. Often these chronic illnesses are debilitating. They really affect quality of life, but they're not fatal. On the invisible side, if you were to look at my daughter, especially if you didn't know what she looked like before she got sick, she looks perfectly well. There really are not good physical indicators on the outside to reflect how ill she feels on the inside. And as a double whammy, when practitioners try to test and figure out what's going on, they can run a bunch of blood and urine and imaging and not find anything that's really abnormal. And so the time to diagnosis is frustratingly long. Right now, from symptom onset to diagnosis is about 2 years. And while that's far too long, a decade ago, when my own daughter was diagnosed, the average was more like 6 years. So we're moving in the right direction, but there's a lot of suffering that's going on with this. And then the third part of that is that this is a real illness, that the average POTS patient has 16 symptoms that cross a variety of organ systems. So some are neurological, some are cardiovascular, gastrointestinal, and other systems as well. So if we can't detect this using blood tests, urine tests, or imaging, how do we diagnose POTS? And really, the best way right now in 2022 is to use a tilt table test, or a cheaper, easier version is the standing test that you can do at home or in the doctor's office. They both use the same idea. You want the person to lay down flat, like my daughter is here, for at least 10 minutes, relaxed, not contracting any muscles, and then take their heart rate and blood pressure. And then you want to have that person be elevated on the tilt table test, or to stand up if you're doing it at home, for up to 10 minutes. And so you wait for 2 minutes, and then you take their heart rate and blood pressure if you can. And you do that every 2 minutes for up to 10 minutes. If at any point the heart rate goes up by 30 beats per minute for an adult, or 40 beats per minute for a child or teenager, then POTS is likely in the picture. Now, I have to say a couple caveats. One, they have to have had symptoms of POTS for at least 6 months. And two, they can't be taking any medication that might cause a heart rate spike like that. So this is a great way to just figure out if POTS might be in that picture for you. So how common is POTS? The joke, and it's not funny, but the joke in the POTS community used to be this is the most common disorder that nobody has ever heard of. The estimate is that 1 to 3 million Americans have POTS. It's more common in women than men, but of course men do get POTS and suffer with it. You can see that it can affect up to 1% of teenagers, so think about those teens that are in our high schools and our colleges. And there are more POTS patients in the United States, whether they've been diagnosed or not, than multiple sclerosis, ALS, and Parkinson's disease put together. So we're talking about a large population of people that really are struggling right now. So what is POTS? Well, POTS is a form of a larger category of illness that's called dysautonomia. Dys means bad or abnormal, and autonomia is talking about the autonomic nervous system. So this is an umbrella term for a variety of different illnesses, but the most common form of dysautonomia is postural orthostatic tachycardia syndrome, or POTS. So this autonomic nervous system can cause all sorts of problems. It controls heart rate, respiratory rate, blood pressure, dilation of the pupil of your eye, movement of food through the gastrointestinal tract. There are so many things that are affected by this autonomic nervous system that you don't think about until it's not working properly. One of the primary symptoms of POTS is something called orthostatic intolerance. And simply what that means is that symptoms are increased when that person stands up. So they may be symptomatic all the time, but upon standing, those symptoms get much worse. So if you look at the EKG recording here, you can see a normal resting heart rate between 60 and 100 beats per minute. We just talked about the fact that in POTS, that heart rate increases after they stand up, right, by 30 or 40 beats per minute. What also increases then are the symptoms. So when that person stands, we see that the blood volume is pulled down by gravity. They have a lot of what we call blood pooling down in the legs and feet, which means that we don't have as much blood up in the head and in the chest. So a lot of these symptoms, dizziness, lightheadedness, headache, are coming from that lack of blood flow to the brain. Well, let's think about how this works. So if we think about this increased heart rate, okay, so we've got our tachycardia. That literally is when there are more than 100 beats per minute at rest. And the heart is really working. The brain sort of gets in the game, right? We've got low blood flow over there. And so the brain doesn't like that. So it activates something called the sympathetic nervous system, which is part of the autonomic nervous system. It's the fight or flight part of the autonomic nervous system. So that starts to release norepinephrine. Well, norepinephrine increases heart rate, but it also causes constriction of the blood vessels. And when we constrict these blood vessels, that's supposed to fight gravity and help push the blood back up towards our heart and our brain. Unfortunately, the blood vessels in a POTS patient don't constrict properly. And so even though this norepinephrine is being released, we're sending the signals, come on now, contract, it doesn't happen. So again, we get this blood pooling. As a result of that blood pooling, we don't have as much blood coming back up to the heart. We call that poor venous return. It literally means not as much blood is coming into the heart for each heartbeat. So in physiology, when we think about the brain and the rest of the body getting enough blood, we talk about something called cardiac output. And cardiac output is heart rate times stroke volume. So my stroke volume, the amount of blood in my heart per stroke or per beat, is down because too much blood is sitting down in my legs. So how can I continue to get blood out to the rest of the body? If my stroke volume's down, I need the heart rate to go up, right? And that's exactly what we see. So this thing circles around and around. It really makes that person feel pretty awful. Let's look at some other symptoms that we see. So it's not just the orthostatic intolerance, although that's a big symptom. There are many symptoms. Remember, autonomic nervous system controls lots of different automatic functions in our body that goes across a variety of symptoms. So as we look at this, both POTS and long COVID share these symptoms in the center. So some neurological symptoms for both include something called brain fog, where people really struggle to concentrate and pay attention and think well. Dizziness upon standing, we just talked about that idea of orthostatic intolerance. And there can be a lot of pain in both syndromes. Could be joint pain, can be pain in the muscles, headaches, chest pain. And I ought to stop here and say, we've already talked about how this is really common in women, but notice that it's really common in young women. We're typically not talking, at least on the outset, about people that are in their 60s, 70s, and 80s, although they could have these syndromes. We're often talking about teenagers, people in their 20s, 30s, 40s, right? So a lot of symptoms there. Depression and anxiety. This is largely related to massive changes in quality of life and everything that goes along with that. Cardiovascular system, that tachycardia, the heart rate goes up over 100 beats per minute at rest. That can lead to fatigue and other things. Heart palpitations, where you literally feel that heart beating in your chest, and shortness of breath are really common both in POTS and in long COVID. Think about how debilitating this is. Some general symptoms. There's something called post-exertional malaise. And really what that means is when I spend a lot of physical or mental effort, that I have rebound fatigue, that I might make it through that short stint, but then I pay on the backside. And for my daughter, often she would have 3 or 4 days where she could barely move out of the recliner. She was so ill as a result of going to school or something that pushed her just a little bit too hard. Sleep problems and fatigue also very common. Now, I want to point out that there are some symptoms that we see in POTS patients that at least right now we're not seeing in long COVID, related to the autonomic nervous system again. So all of these are things that the autonomic nervous system is doing. And then some of the symptoms of long COVID that we don't see in POTS, that we've seen on the news, right? That long-standing fever, cough, rash, diarrhea, and that change in taste and smell. There are other things, though, that POTS and long COVID share. And one is that they can both happen after infection. So I mentioned before that my daughter got sick shortly after she turned 10, and we think that that was mono. And about 41% of POTS cases are thought to be triggered by a viral illness or another illness. So mono is a common one, Lyme disease, and of course now COVID is triggering POTS in folks. And of course for long COVID, 100% of people with long COVID are thought to have had that infection. So both of them can follow infection. And we see that about 10 to 30% of all COVID cases are thought to go on and have long COVID. So this is really interesting to think about how we've got these overlapping autonomic symptoms in both POTS and long COVID. The question is why? Why would this be? Why would a virus trigger this kind of long-term symptom activation? And this is a hypothesis. We're early. These are early days as far as the science here. So I'm going to float an idea. It may be right. Maybe we'll find in a few years that it's not right. But there's a lot of evidence right now pointing towards mast cell activation syndrome, that maybe this is the missing link. So if you're unfamiliar with mast cells, a good way to think about them is to think about the guards on a castle. You post guards at every entrance and exit, and you also have them up on the rooftop. And they are really looking for near and far dangers, right? And these mast cells are spread through the body in a similar way. Any place in our body that we have an environmental interface, we're going to post a guard. We're going to post mast cells there. So that would be thinking COVID about the respiratory tract, also in our GI tract, our digestive tract, the genitourinary tract, skin, and blood vessel walls. So we find these all over the place in the body, again, looking for danger. These mast cells are actually quite complex and can release more than 1,000 different mediators. I've listed some of the common ones here. We're going to come back and talk about the chemokines and cytokines in a minute as part of my hypothesis here. But another piece of circumstantial evidence is that the mast cells express angiotensin converting enzyme 2. And we know that this is the way that the COVID virus, its technical name is SARS-CoV-2. So the SARS-CoV-2 virus can get into your body cells, and in this case, into the mast cells. So there's a direct connection now between that COVID virus and these mast cells. Let me give you some other circumstantial evidence. There are medications that are pretty effective in treating both long COVID and POTS that work by inhibiting mast cell activation. They help to stabilize the mast cells so that they're not releasing all of these mediators. And for my daughter, one of the best things that we ever tried were antihistamines. And they decreased her symptoms more than any other single thing that we did in her 10-year journey. And she still takes Zyrtec and Pepcid AC twice a day. But Zyrtec is a histamine 1 inhibitor or antagonist. Pepcid AC is a histamine 2 antagonist or inhibitor. Benadryl hits both of those receptors. And then there's something called quercetin. This is a natural supplement. And so all four of those actually, I guess, are over the counter that you can get that stabilizes the mast cells. And then a lot of folks that have been diagnosed with mast cell activation will take cromolyn or other medications. Another piece of circumstantial evidence is that about 17% of the population is thought to have MCAS. The folks that we're talking about here may have a more severe form. There are other people maybe that haven't been diagnosed that have lesser forms. But what's really interesting is that 17% really corresponds with the percentage of people that develop a severe COVID infection. Circumstantial, but interesting. So let me go a little further with this hypothesis and thinking about how a COVID infection, or in my daughter's case, a monoinfection, might activate these mast cells. Okay, so let's focus on COVID. So that virus, again, it's called the SARS-CoV-2 virus, can cause a lot of different physiological reactions in the body. And you've probably heard on the news that not everyone that gets long COVID was hospitalized with COVID. So mild and moderate cases of COVID infection can result in long COVID. So let's think about this a little bit. This virus can cause dysregulation of our mast cells. And I mentioned that the mast cells were the guards of our castle, right? And so when they see what they perceive to be danger, they can activate our nonspecific defenses against that, that would be inflammation and fever, as well as the specific defenses of our immune system, which would be cellular and humoral immunity. So these mast cells can turn on our immune system. In addition to that, they recruit immune cells to the inflamed tissue. And so often in COVID, it's a respiratory disorder, right, or disease. So we're talking about going to the lungs. So it's bringing lots of immune cells in to try to kill that. And then I mentioned before that mast cells can release cytokines and chemokines. So normally they have a really important function. But what we just said was that this virus can dysregulate those. So they can become overactive. They can maybe release mediators that they should not be releasing and wreak all sorts of havoc. Interesting to think about. Cytokine storm. So I just said that these mast cells can release cytokines and chemokines as part of the mediators that they have. But the cytokine storms itself can further activate mast cells. So we've got this cyclical problem going on here now. The more we activate the mast cells, the more they release their own cytokines and chemokines. And I ought to say that not all cytokines and chemokines are pro-inflammatory, but a lot of the ones we're talking about here are. They also activate microglia. These are support cells that are found in your nervous system that usually proliferate and gather in places of infection and trauma. And then also these cytokine storms can induce mutations in the somatic stem cells, including the stem cells for our mast cells. So this is like a triple whammy here, right? Where the cytokine storms may be activating the cells, they may be causing mutations in the stem cells, and now they're dysregulated too. I'm going to add another one. Oh my goodness. So autoantibodies. Antibodies are part of the immune system. So the plasma B cells of humoral immunity release these, and they're good. Their job is to try to help us fight infection. An autoantibody is going against your good normal tissue. So we don't want autoantibodies. But we know that autoantibodies that are made in COVID infection or with COVID infection can react with mast cells. And a different study showed that 20% of folks that had serious COVID cases, so they were hospitalized or died from COVID, had autoantibodies in the blood. And so these autoantibodies can also react with these mast cells. So there's a lot of sort of initial interesting tidbits that point to a role for these mast cells in long COVID. Let me go a little further, show you a different study here. And I'm going to start with long COVID, okay? So I don't know if you've seen plots like these. They're called spiderweb plots. And so around the periphery, we're listing a variety of symptoms, and they're in the same order for each one of these plots. On the left-hand side, we're looking at the general population. So these are people that don't have MCAS or long COVID. And the bottom plot is people that developed long COVID reporting how they felt, what kind of symptoms they had before they ever had COVID. So sort of their baseline. And what you see is that it looks very, very similar, okay? If we go to the right-hand side over here, we look at the plot and the pattern for people that have mast cell activation syndrome. And at the bottom, again, the same order of symptoms, we're looking at a similar plot for people that have long COVID. And again, they're not exactly identical, but boy, they look similar, don't they? Circumstantial evidence? Yes. Interesting? Very, I think. And then I mentioned the autoantibodies before. I just didn't want to lose that fact. In POTS, and we've had more time to study POTS, more time to figure some of this stuff out, about 42% of people with POTS show at least one marker of mast cell activation syndrome. So that's much higher than the general population, and also gives a potential underlying cause in POTS. Another study showed that 89% of people with POTS have at least one autoantibody. Now, I think that we're going to see an increase in the percentage of autoantibodies in long COVID. We've just started looking. The autoantibody theory of POTS has been around for a while, and they've found a number of different markers. So we're in early days for long COVID, but again, just very interesting. And remember that this idea that if it's an autoimmune disease doesn't necessarily mean that it's not mast cells. We talked about how those autoantibodies can interact with the mast cells. Very interesting, I think. So why should we care? Why am I here talking about this? And the reason for that is that these disorders, like I said before, are chronic, and they have a significant impact on the quality of life for people with POTS and long COVID. So the data I'm pulling here is from a study that I did a few years ago before the pandemic, but I'm pretty confident that we would see similar things in long COVID. So these are debilitating disorders. When you compare POTS patients to people that don't have POTS or any chronic illness, some of these are things that you would expect, right? More days of poor health, increased pain, poor sleep quality. We talked about that already. But the next one was shocking, and that was that 30% of POTS patients in our study, and we looked at more than 650 people, required help with activities of daily living. And the average age of people in that particular study was 32. So again, we're talking about people in their 20s, 30s, 40s. We're not talking about people, although there could be, that are in their 60s, 70s, 80s. And so that's devastating. We're talking about people your age as you're listening to this. And then what really almost knocked us over was that almost 50% fell into a high-risk category for suicide. The actual number was 48.6% in this first study. We've had other studies that have been higher than that, so over 50%. And so we got to do something about this. We've got to figure out how to improve quality of life and get people their lives back. So problem number one is quality of life is a real issue. It's invisible, right? So you can't tell by looking how impactful this can be. And third is we don't have good treatments. Right now, there are no FDA-approved medications for either POTS or long COVID. And so what that forces practitioners to do is use off-label medications. That means that these are FDA approved for other things, for blood pressure or for congestive heart failure or for other sorts of things, but they've not been tested in POTS patients or long COVID patients. So that's one problem. The second problem is we're playing whack-a-mole. I mean, to be really honest. So what the physicians or the practitioners are doing is they're trying to treat individual symptoms. Oh, is your blood pressure too low? Let me give you something that'll increase that. Oh, your heart rate's really, and heart palpitations are problematic. Let me give you some beta blockers to take care of that. Your sympathetic tone is too high. Let me give you some clonidine. And so it's all this trying to deal with individual symptoms, but we're not able to get at the root cause. Why? We don't understand the root cause. So what I'm trying to say to you today is that mast cells may be part of that. But right now, we are treating symptoms as they pop up and not treating the underlying condition. We need more research under the underlying cause into the best treatment for these particular categories of symptoms, and we're hoping that it's coming. I think one of the silver linings of this pandemic is that I'm invited to do talks like this, that folks are interested in these disorders. Research funding is coming finally from NIH, and it's all a good thing. So in closing, I just want to sort of remind you where we've been. Both POTS and long COVID are chronic invisible illnesses. They both seem to be affecting this autonomic nervous system, the automatic part, that really can wreak havoc with quality of life. The cause, or the changes in our physiology post-infection that lead to POTS and COVID, or in POTS it can be even more complicated. It can be concussion, it can be pregnancy, it can be surgery. There are a number of things that people point to as their trigger. So what's going on there physiologically that's preventing people from healing and going back on with their lives? And then the treatments, right? Right now, because we don't understand the cause, it's very difficult to have good treatment. So we need research to really help folks that are living with these disorders. So I appreciate you listening to this all the way to the end, and I hope you have a great rest of your day.